filling the alveoli with the proteinaceous fluid and hence compromising the gaseous exchange in the lungs. All these changes lead to pneumonia and more severely acute respiratory distress syndrome. So the patient will present. What is the presentation of COVID-19 patients? The good news is that 80%, more than 80% patients have mild disease. Those present with the commonest symptoms are fever, cough, and shortness of breath, myalgia, fatigue, and they can present less commonly with anorexia, sore throat, sputum production, headache, confusion, rhinorrhea, chest pain, hemoptysis, diarrhea, nausea and vomiting, and abdominal pain. So, what are the warning signs? If we see in a patient, then we should consider admitting this patient. We can't admit each and every patient. We should look for these signs. If there is tachypnea, if there is tachycardia, if there is cyanosis, or bronchial breathing with crackles on chest auscultation. If we find one of these findings, we should consider admitting the patient. After admitting the patient, there should be some investigations, pulse oximetry, which may show saturation, oxygen saturation less than 90%, ABGs, which will show hypoxia, hypercarbia, and metabolic acidosis, full blood count, which can show leukopenia. It can show leukocytosis, lymphopenia, thrombocytopenia. Leukopenia, or more specifically neutropenia, is a worst prognostic feature in COVID-19. We should do coagulation screen. There will be elevated D-dimers and prolonged PT. Again, elevated D-dimer is a worst prognostic feature. Then we should do metabolic panel. There will be deranged liver function and renal functions. It indicates the multi-organ involvement. CRP rise shows secondary bacterial infection. LDH elevation indicates liver injury and hemolysis, and it is another bad prognostic factor for the COVID-19. CK, creatinine kinase, and troponin may be raised, and it shows myocardial injury. We should do blood cultures and sputum cultures to rule out other causes of pneumonia, like atypical pneumonia. Here is the most specific test for this COVID-19 SARS-CoV-2 infection, real-time reverse transcription PCR. It should be done. It will be positive for SARS-CoV-2 and it will be negative for other viruses like influenza virus, like SARS-CoV-1 virus. It can be done on nasopharyngeal swab, throat swab, sputum, and bronchial alveolar lavage. If the suspicion of COVID-19 or SARS-CoV-2 infection is high and test comes out to be negative, you should go and repeat it. Then radiology should be done, X-ray chest, there should be bilateral pneumonia. CT scan has better sensitivity and it can also be done. So going into the management of pneumonia and acute respiratory distress syndrome in COVID-19 patient, what are the goals of management? So the first and most important goal is ensure adequate oxygenation. Patient shouldn't be hypoxic. Second is hemodynamic support during acute phase of illness. Third is prevent end organ damage. So basically, acute pneumonia, severe pneumonia, acute respiratory distress syndrome, septic shock, MI, CNS involvement, these all are basically severe COVID-19 infection, and these need to be dealt by multidisciplinary approach with the involvement of infectious disease specialist, pulmonologist, and intensivist. So what is the admission criteria? Who should you admit and who should you send home? So if you see radiographic evidence of pneumonia either on X-ray or CT scan, you should admit the patient. If the disease is progressing and the condition is worsening, you should admit the patient. If there are risk factors for the severe disease, for example, if the patient is elderly or there are comorbidities like the patient is diabetic, is hypertensive, patient is having ischemic heart disease, or patient is having malignancy, etc., So you should admit these patients. Or if you consider that the patient can take care of itself, or there is no caregiver at home, then you should also admit these patients as well. CDC provides guidance for determining whether the home is suitable venue for a patient and caregiver is capable of adhering medical care recommendations or not. So initial management. It should be kept in mind that there is no approved treatment up till now for COVID-19. Treatment is basically supportive. Give antipyretic, give fluids, but avoid fluid overload. Give oxygen through nasal cannula and aiming saturation of 94%. Give empiric antibiotics for sepsis if secondary infection is suspected, and monitor the vital signs, oxygen saturation, etc., which might be a criteria for shifting the patient to ICU and intubate. So this is the criteria for ICU admission. There are two criteria basically. Patient is having severe pneumonia or the patient is having severe complications like septic shock or acute respiratory distress syndrome. So WHO has provided a criteria for a severe pneumonia. There should be three things. One is tachypnea, severe tachypnea, that is respiratory rate of greater than 30 beats per minute. Second is respiratory distress. If the patient breathing is obstructed, patient is having cyanosis, you should admit and shift the patient to ICU. And if there is inadequate oxygenation in spite of supplemental oxygen, that is saturation is 90% or less, oxygen saturation is less than 90%, then you should shift the patient to ICU. Or the patient is having acute respiratory distress syndrome. So what is acute respiratory distress syndrome? By definition, acute respiratory distress syndrome is severe and often fatal acute respiratory failure characterized by diffuse inflammatory lung injury, rapidly progressing to increased pulmonary vascular permeability, increased lung weight, and hypoxia. So looking into the definition, we can have a criteria for acute respiratory distress syndrome. Berlin criteria for acute respiratory distress syndrome has been produced, which has 4 points. One is the symptoms should be of acute onset, that is, it should be within 1 week of clinical insight. Second thing, there should be hypoxia, which can be measured by the ratio of partial pressure of oxygen to the fraction of oxygen in inspired air, and it should be 300 or less. Normally, this ratio is above 300